16-year-old male with advanced keratoconus in his left eye with best corrected visual acuity of 3 by 60 was planned for DALK. Partial trephination using vacuum trephine is performed to a depth of 80%. Intrastromal air injection using 30-gauge needle is done at 80% depth to achieve type 1 bubble. First attempt fails to create type 1 bubble. Second attempt is made to create the desired type 1 bubble. One can see the formation of type 1 bubble starting in the center and moving out in periphery. Superficial stromal dissection is performed to a depth of 50% using crescent knife. It is important to maintain the plane of dissection at same level while dissecting out the stroma. Gentian violet marker is used to mark the site of brave slash. Side cord is used to puncture the bubble at the marked site. Viscodissection is performed to separate the stroma from Dua's layer. Stroma is divided into 4 quadrants using vanas and is dissected out. Full thickness donor stroma is placed and 16 sutures are applied at equidistance using 10-0 nylon. Post-op day 1, the patient has minimal stromal edema and good visual recovery. Second case, the case of 55-year-old male with central leukomatous corneal opacity, status post healed fungal ulcer, having a visual acuity of counting finger at 1 meter. Partial trephination to 80% of depth is performed using Barron's trephine. Superficial stromal dissection to 50% depth is performed using crescent knife. Vanas is used to dissect out the stroma in periphery. Intrastromal injection of air using 30-gauge needle is done in an attempt to create type 1 bubble. First attempt to create type 1 bubble fails. On second attempt, one can see the formation of air bubble starting in the periphery and moving towards center with the peripheral glistening reflex suggestive of type 2 bubble. Type 2 bubble is deflated and third attempt is made to create the desired type 1 bubble. This time again, the air enters below the Dua's layer, enlarging our existing type 2 bubble. A layer by layer manual dissection is performed using crescent knife. Side port is used to deflate the type 2 bubble in the periphery. Inadvertent perforation of type 2 bubble happens in an attempt to enter deeper plane. Viscodissection of the stroma and the bare desmet is performed. Anterior chamber is decompressed using air cannula to prevent rupture of bare desmet. Visco is injected to float the stroma and vanas is used to dissect out the stroma. Care is taken that at no point the tip of vana touches the bare desmet. Stromal lamella seems to be tightly adherent to the desmet. Attempt is made to nibble the edges of stromal lamella so that they don't come in the visual axis. full thickness donor stromal cap is placed and 16 sutures are applied at equidistance using 10-0 nylon. A 146 micron residual stromal lenticule can be seen on ASO-CT. Though the patient had cataract, he achieved a visual acuity of 618. Post-stromal lenticule can be seen off the visual axis. Thus, it is important to modify the technique of DALK on the type of bubble we achieve. One must always try to save the host desmet for early visual rehabilitation and the immune privileges the patient achieves with DALK rather than converting it into penetrating keratoplasty.